Hi, um, I'm here to briefly introduce Dr. Gerda Mazel. Some of you must know her from her two prior talks here, one 3 years ago, one 2 years ago, something like that. And some of you know her late mother, who was here till the day she died in her own bed, um, Raina Mazel. And it's already a year. Yeah. Um, anyway, so Gert is kind enough to talk to us about some medical conditions that you can never hear enough about because there's always something new to learn about. I think that's what it's called.
Well, thanks very much. This is always a little awkward here. Okay. So it's great to be here. I'm glad to be here. And we're going to do questions at the end, but I'm only going to do 3 conditions because if anybody's come to my other talks, I always run out of time. So this time I have less stuff. I have many other medical conditions to talk about, but we're only going to do 3 today. Oh, and I need to find the little clicky thing. All right. Got the clicky thing. All right. So have you ever been to the doctor's office and hold it up close? Have you ever been to the doctor's office and not quite been able to follow the conversation? Don't know if that's happened to you, but it can be hard to speak doctor. It's its own language. So I'm here today to help you speak doctor just a little bit better so that you can ask the right questions. Today, let's see if I can get it to switch. I'm only doing 3 conditions, and I'm not doing the obvious ones. I'm not doing diabetes. We're going to talk about arthritis, back pain, neck pain, and bladder. And the reason that I picked those, I am a physician, but I'm a private patient advocate. I left the whole corporate medicine world behind about 5 years ago, and now I help people get better medical care. And these things come up a lot as areas that people need extra help figuring out the resources, asking the right questions. So that's how I picked them. And as I mentioned, we're doing questions at the end. Okay, first up. When I was working in Philadelphia, I had this little old lady who would come back to me. Now I realize she probably wasn't so old, but I was 20 something. She would come back and visit, and she always talked about her, do I get to the pointer? Her Arthur, it's not pointing, but you can see her arthritis. So I can never talk about arthritis without thinking of arthritis. Okay, so arthritis. Arthritis is specifically pain in your joints, often with inflammation and stiffness and reduced range of motion. If you get fluid in your joint, what's the medical term for that fluid? It's an effusion. Okay, so that often goes along with arthritis, and you get let me see if I'm going to try one more time to make the pointer thing work. I'm failing. Nah, never mind. I'll do this. So you can get swelling with arthritis. You can get swelling in your knee. You can get inflammation in your joint. If you have chronic conditions, like being heavy, being obese, or having diabetes, you have an even higher chance of getting arthritis than the average person. And it's about 60% of people have some form of arthritis. There's 3 forms of arthritis, and you're going to hear these different terms, so I want you to have the vocabulary. There is osteoarthritis. What's the other term for osteoarthritis? Rheumatoid and inflammatory arthritis, but good guess. Osteoarthritis is also called DJD. Well, what the heck's DJD? Degenerative joint disease. Now, when you hear the term degenerative joint disease, that does not mean your joints are falling apart. It's not degenerating into a pile of dirt. It's just degenerative in the sense of it's a wear and tear arthritis. So osteoarthritis is the same thing as DJD, is the same thing as degenerative joint disease. Okay, and that's the most common form. Now, many of us who are having pain in a joint will assume that it's arthritis. And I'm going to use myself as an example. So a couple days ago, I was having this pain in my hip. And I went, oh, I know I already have a little osteoarthritis. I'm in my mid-60s. I already have a little osteoarthritis. Oh, I wonder how long it's going to be before I need a hip replacement. Oh, and I had like had this whole thing in my head created. And then the next morning I woke up and I thought, well, this pain's actually here on the side of my leg. Well, do you know where where hip joints hurt? If it's actually your hip joint, it's not the side of your leg. It's your groin, the acetabulum. It's the groin that hurts. So then I started to think, why am I having lateral pain? And I realized what I have is a gluteal tendinopathy. Why did I have a gluteal tendinopathy? I was trying to improve my assets. And I was doing these weightlifting things. And I gave myself a very mild gluteal tendinopathy. And I mentioned, and I realized what I was doing. I lightened up on the weight for a few days, stretched it out, and I was fine. But the point is that not all pain around a joint is arthritis. There are tendons and other structures that can hurt. Okay, bone on bone. That's another phrase I want to make sure you understand. Okay, I can't, since I don't have a pointer thingy, that is a hip. So this is half a pelvis. That's the femur bone. That roundy thing up there going into the pelvis is the ball of the hip. And this is the femur. That ball of the hip is going in. And can you see how there's these two white lines? In between those two white lines is gray. That gray is joint space. This one on the left is normal because it's got that gray stripe. Over time, the cartilage wears down. In osteoarthritis, you get this wear and tear, wear and tear. Over here, can you see how there's not the same gray, nice little band of gray joint space? That's bone on bone. And bone on bone, you can see very quickly on an x-ray, and it hurts. That person with the far hip, that person might need a hip replacement because you can't fix it without replacing it. Okay, but so that's what bone on bone means. It's tight, it goes along with osteoarthritis. Okay, next type, inflammatory arthritis. Somebody had mentioned rheumatoid arthritis. That is a type of inflammatory arthritis. Inflammatory arthritis includes gout, pseudo-gout, autoimmune-based arthritis like rheumatoid, ankylosing spondylitis, lupus, that whole group. We as doctors start to think about an inflammatory arthritis, especially the systemic ones like rheumatoid, when a person doesn't feel well. In osteoarthritis, you feel fine, you just hurt. In rheumatoid arthritis, you often don't feel good overall. You're fatigued, multiple joints are involved. Same kind of thing with lupus or ankylosing spondylitis. So if something like that comes up where you've got multiple joints involved and you're not feeling well, maybe you have a fever, go see a rheumatologist because these days there's tons of great drugs. So when I was in medical school, this hand was a common thing. That's a hand before all the fancy drugs came in, somebody with rheumatoid arthritis. Their hands we would get ulnar deviation. Their hands, they got all this inflammation in this joint here. Now it's so much better. You don't see people with those hands anymore because the drugs and treatments have improved. Does anybody know what this is here? You got it. It's gout. That's the classic place in that big toe first joint there. The last category for arthritis, for causes of arthritis, is infections. Third one there. Not common, but you can get all kinds of things causing infections. You can get virus. You can get staph infections. You can get gonorrhea in a joint. Tuberculosis, all can cause joint swelling. As doctors, we can't tell whether you've got gonorrhea in your joint or you've just got a bad effusion. So that's why if you have a lot of swelling, the doctor will go in with a needle and pull out some of that effusion, some of that fluid, and send it off to the lab. Because when we look at the fluid, the different causes of arthritis cause different stuff in that fluid, cells, protein patterns, and we can tell what it is when we can look at the fluid in the lab. Hopefully that makes sense. All right. I would be remiss to talk about arthritis if I didn't talk about joint replacements. So boomers are aging, so joint replacements are booming. Sorry. There's more and more joint replacements happening. Knee replacements, we're talking 1.3 million a year and climbing. Hip replacements, less than knees, 760, 780, 100,000, 780,000 on Americans every year. After, and I bet you there are people in this room who've had hips and knees replaced because it's common. And in general, the outcome is good. Nobody likes the rehab and the recovery, but you can be pain-free on the other side and you can get your walking back. Shoulder replacements are coming now. For years, we didn't touch shoulders, but now we're starting to see more and more shoulder replacements being done. Trends in joint replacements. We're seeing more joint replacements than ever before. They're being done in younger people than ever before. Part of why they're being done in younger people is back in the day when I went through in the 90s, we told people to hold off because the joint replacements only lasted 10 years. So if you were 70 and we thought you might live into your 90s, or if you were 60, and we would say, can you wait? Can you wait? Now these things are lasting 20 plus years. So there's not that hold off. They tell you now you'll know when it's time for your knee or your hip to be replaced because you'll be fed up with your loss of function. And the other big trend that you're probably aware of, it used to be that if you had a joint replacement done, you went and stayed in rehab for a month, 2 months. A lot of people are going straight home now, which then requires you to have a lot of help because just because you're home doesn't mean you can get on and off the john by yourself. So, but you'll see if you haven't had one or approaching it, many times now these joint replacements are done as same-day surgery and then they send you home. That might keep you overnight, but you go home. Oh, and in case this wasn't obvious, do you know what joint that is? That's a knee, right? And that's a total knee, also called a TKA, total knee arthroplasty. We're holding off on questions unless you want to make a clarifying point. Okay, yeah, so, but write it down, please, because I don't want you to forget it and I want to hear your question. But they're doing both sides of the joint there. Okay, on to back pain. Most people will have, over 80% of people will have a significant bout of knee or back pain in their lifetime. So I had a client, his name was Kevin. He had pain that shot down from his neck down his arm. And Kevin was having a hard time driving because every time he turned his head, this horrible pain would shoot down his arm. And if you're going to drive, you got to turn your head. And he was also getting tingling in his fingers and his arm seemed a little bit weaker. And so he went to see his primary care doctor who ordered an x-ray and said, well, see a little arthritis. Sent him off to PT, still had pain. So then he went back and he got the doctor to order an MRI. Went back to the primary care doctor. Primary care doctor said, yeah, you got arthritis. That's at which point he had so much pain, he knew there was something else going on. And this was a new problem. So he contacted me and I, ended up working with him. Well, I looked at the MRI And he had what's known as, and I'll explain what it is in a second, a disc osteophyte complex. He had a disc and an osteophyte pushing on a nerve root. So I encouraged him to go back to his PCP and just ask a little bit more about that MRI. Well, the guy took a second look and he's like, oh, yeah, maybe there is something here. And said, well, why don't you go see the local neurosurgeon? So he goes to see the local neurosurgeon, and the local neurosurgeon says, yeah, you've got a problem. Go get an epidural. Here are some exercises. Well, at that point, and this was actually in this area, at that point, he said, there's something more than this. I don't know if I want to keep messing around. So I asked him what he wanted to do, and I happen to be a huge believer in second opinions, even third or fourth opinions, when you have something that's impairing what you want to do. So what we decided to do is I found for him the two, I call them the fancy pants doctors in New York, one at Mount Sinai and one at Hospital for Special Surgery that specialize in the kind of problem he had. So within about a week of each other, he had these two appointments. Guess what? They had identical opinions. Both said, the epidural's not going to do anything for you. Both said, you need a microdiscectomy. He said, okay. He got the microdiscectomy. Pain went away. Still has some numbness in his hand, but the pain is gone. And both surgeons in New York said, because you had to go through this whole process, you're going to be left with residual numbness because they waited too long. If it was done in less than 6 months, you wouldn't have had residual numbness. So get second or third opinions till you know that you're comfortable with the advice that you're being given. Okay. Let's do some anatomy. So this is the same thing as this. Only in this case, they're just turned kind of like this, whereas this one is completely sideways. And the reason is to show you this space. This space is where it matters. Here's the front, here's the back. So front, back. These are the spinous processes, those bumps that you feel up and down your spine, they're in your back. They're in the back here. These are the vertebral bodies that we've all heard about. These are the discs. What are these dark spaces? Anybody know the name of them? Those are the foramen. It's window in Latin, foramen. Why do we care about the foramen? There needs to be spaces because what's going through that space? The nerves, you got it. So the spinal cord is running inside between the spinous processes and the vertebrae, up and down in this space. Up and down in here is where the spinal cord is. And coming off your spinal cord at each level are nerve roots. One goes right, one goes left. Those nerve roots become the nerves that go to your arms and your legs and your trunk. If that window gets smaller, instead of like this, it's like this, it's going to squish that nerve root. And that hurts. That really hurts. And it can cause numbness and it can cause weakness. So why would that window get smaller? If your disc bulges backwards or herniates, it squishes itself right into the window. And that's why you always hear, oh, I slipped a disc, I herniated a disc. What that means is that soft, squishy disc pushed back and is now sitting on a nerve root and irritating the heck out of that nerve root. The other thing that can narrow that space commonly is an osteophyte. Don't know if you know the term. An osteophyte is common with aging. It's a type of arthritis. So see how this is sort of smooth? I don't know if you can see it, but there's these little pokey up areas, up and down. This curves down, this pokes up, that pokes up. Those are osteophytes. They're little extra bits of bone. So remember I mentioned Kevin had a disc osteophyte complex? He had a combination of a disc that was squishing out and a bit of some osteophytes that were also narrowing the space. And the only way to fix that was to take a piece of the disc out and open up the space, which is why the opinion of getting epidural in his case wasn't the right opinion. He needed to have decompression basically of the space, and it worked. Do you know the name when a nerve is squished at the root? So this is, the spinal cord and then the nerve root as it leaves and it goes down. There's a specific medical term for that. It's called a radiculopathy. I'm sure you've heard that term. It sounds like ridiculous. You're like, oh, it's ridiculous to have a radiculopathy. But it's a radiculopathy. We often shortcut it and just say somebody has a radic. But that's what a radic is, or a radiculopathy. It's where the nerve comes out of the spinal cord, it's getting squished and causing problems. Okay? I wanted you to have this vocabulary because it's such a common problem and it's so confusing if you don't have the basic anatomy in your mind. You know what body part this is? It's a foot. It's a foot doing this. So that's the heel and that's the toes. The reason that I've got the foot here is, see that little spiky thing? That's an osteophyte. So I just wanted you to have another illustration of what osteophytes can look like in other spaces. So if you've got an osteophyte in your foot, what's it called? Yes, bone spur. That is correct. Bone spurs have been around for a while. Some people use them for certain conditions. Okay. Some people exaggerate them. All right. Just a couple, and I won't spend too much time on this, but danger signals. So when you have pain in your back, it feels like an emergency because you really hurt. And sometimes when people go to the doctor's like, oh yeah, another back pain person, because a lot of people have pain. But there are a couple things that are true medical red flags, urgent emergent issues that I want you to just be aware of. So one, that person has new onset of spinal pain and unintentional weight loss, and that's a metastasis. Okay? There are 3 cancers that commonly go to bone. We call them the BLP cancers. The BLP cancers go to bone: breast, lung, prostate. So in a person who has a history of those, or a person who's had weight loss and a sudden onset of horrible pain, we worry about a metastasis from a cancer. The other thing that is an urgent issue is what's called cauda equina syndrome. This is a front view. The end of your spinal cord is known as the cauda equina. If you're good at Latin, cauda equina, equina is horse, cauda is tail. So because that end of your spinal cord looks like a horse tail, it's called cauda equina. If that gets squished from whatever reason, you can have sudden loss of bowel and bladder function along with numbness in your crotch and weakness in your legs. So it doesn't happen very often, but if all of a sudden somebody has perineal, this area under here, numbness and leg weakness and a sudden change, loss of bowel and bladder, they need to be evaluated. Okay, we're done with that one. Okay, we're cruising along. We're going to have time for questions. Our favorite subject, the one that nobody likes to talk about. It's even worse than talking about counseling. Bladders. I mean, people talk about them, but people often think, oh, I'm just getting old. There's nothing to be done. Or I've seen a lot of people have a complaint about their bladder and they go and the doctor gives them another pill. or some pill is causing bladder problems. So it's a particular favorite of mine. So I had a client who had what's known as urge incontinence. One of the common symptoms of bladder problems is urgency. It's the I gotta go when I gotta go set of symptoms. You just really suddenly have to go. And when you suddenly really have to go, sometimes you lose control of your bladder in some cases. Well, this client had urge incontinence. She was getting to the point where she was waking up like every hour or two at night. Sometimes she was losing full control of her bladder, and it was driving her bonkers. So she went and she saw a urogynecologist. And it was actually a very academic urogynecologist. And this academic urogynecologist talked to her about all the fancy meds and talked to her about now there are certain, like there's tibial nerve stimulation and all kinds of things that could be done. She also went, and with my encouragement, for a second opinion. It's that second opinion thing again. So this second doctor took a little bit of a different history. And she mentions, she asked what she eats and drinks. And that seemed like an odd thing to take a detailed history on. But it turns out that she drank a lot of coffee, a lot of tea, ate a lot of chocolate, loved her curry. She ate tomato salad all the time, and she loved citrus. Everything that I just mentioned, spicy food, citrus, caffeinated beverages, acidic beverages, even decaf coffee, all of those things can irritate the bladder. And they don't talk about it. So my particular client decided, you know what, I want to control my bladder. I don't want to take drugs if I have to. So she weaned herself off of coffee. She made some dietary changes. And now, while she still has urgency sometimes, the incontinence is gone. And she knows she's going to have urgency under certain conditions. Like if she eats that tomato salad, you know, she does that when she knows she's going to be like near a bathroom with it. I don't know what the exact time frame within the next day or so. Now, I'm not saying that changing your diet is going to cure everybody's bladder urgency, but I am saying it because doctors rarely bring this fact up. If you get online and you Google bladder irritants, you're going to find a list of all kinds of food and beverage that you can play around with and see what might be irritating your bladder. I mean, and this is not to keep telling you client stories, but I'm telling another client story. Just this week, last week, on Friday, I had a client, it was a man actually this time. Am I not being consistent with this? Thank you. I had a client, a man, not a woman, who was having so much bladder urgency that he didn't want to leave the house. He stayed in his apartment. When his daughters would try to come and take him out, he didn't want to go out because he was afraid he was going to lose control. And the daughters started putting him in a Depends, which he found a bit humiliating, but he started wearing. They thought that, well, he's just got an anxiety problem. So I said, do you want to go see a urologist? So we went to go see the urologist, and the urologist immediately started talking about medications and about, his prostate. And his prostate may or may not be an issue in this. But he didn't want another person who didn't really want to take medicines. In bladders, there's 3 types of medicines. In men, there's a medicine that will shrink the size of your prostate. That doesn't tend to have a lot of side effects. There's a medicine for the overactive bladder, which can cause some cognitive side effects, meaning can make confusion worse. And there's a medicine that can help you pee better. It's an alpha-2 blocker that allows Flomax as an example. Those Flomax and those kinds of drugs contribute to falls because they drop your blood pressure when you stand up. So he wanted not to take medicines if he could help it. So the doctor was sort of pushing some of the medicines on him. And so I just asked, doctor, what do you think of, he hasn't made any dietary modifications. Is there any role here? And then the doctor was like, oh, yes, blah, 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 and started talking all about dietary modifications. So now, I don't know, I don't have an end of the story for you because it just happened, but he's willing to give it a try to see if he can do a little bladder retraining and a little dietary modification to reduce his urgency. Okay, a little anatomy. So I tell you a story and then now you're ready for the anatomy, right? So you have your kidneys and you have your bladder, male and female. The tubes that connect your kidneys to your bladder are your ureters, not to be confused with your urethra. Your urethra is the little tube from the bladder to the outside. The urethra is only about an inch long in women. It can be 7-8 inches long in men, which is why women for their whole lives have always been more prone to urinary tract infections. There's just not a lot of distance there. And that bacteria on the outside can crawl up and have a party in the bladder. Okay. Types of incontinence. There's 3 main types of incontinence: stress, urge, and overflow. Stress incontinence is the I sneeze, I cough, I pee kind of incontinence. Very, very common for women after childbirth because your pelvic floor just isn't supporting things. Stress incontinence tends to be also associated with people who are obese and have big bellies, because if you've got a lot weighing down on your bladder, that poor little sphincter just can't hold its own. And so if you cough or pee, a little bit comes out because you briefly overwhelmed that sphincter. Men can get stress incontinence after prostate surgery. Pelvic floor therapy can help a lot with stress incontinence. There are pelvic physical therapists out there who can teach you how to strengthen those muscles and make stress incontinence better. Urge incontinence is also, and you've seen the ads, is the overactive bladder. That's the overactive bladder is the bladder that, oh my God, I got to go, because the bladder is contracting. It's overactive. It's contracting too much. And the bladder will sometimes signal that it needs to contract when there's not even that much pee in there. And so people with urge incontinence or just urgency will find themselves going a little bit a lot. Overflow incontinence, it happens and it's the least common, but it's the one that I see people making a mistake about. Because overflow incontinence, sometimes there's a reason why the person can't empty their bladder. In men and a very large prostate, it can prevent them from fully emptying their bladder. There can be neurologic reasons. And if you don't empty your bladder, eventually some of it's just going to leak out. And the reason that we care about all of that is that if you have a lot of urinary retention, you're a setup for multiple urinary tract infections, because that urine in the bladder, if it's just sitting in there, it's where the bacteria like to party, and they're going to get in there and they're going to grow and they're going to party. And a common mistake of caregivers is they say, well, she can't be having any retention. She pees regularly. Unless you do specific tests, you don't know if somebody is having retention. And the tests are easy. You may or may not have encountered it yourself. It's a little ultrasound that they'll do in the hospital sometimes to make sure you've emptied. The reason they do that, it's called a post-void residual, post-after-void residual. The reason they do that is that it might need to be treated if you aren't retaining. So for somebody with repeated urinary tract infections, make sure your retention is ruled out. All right, we're going to talk a little bit about UTIs, and we're almost done with all this, and then we'll do questions. So UTIs, urinary tract infections, are really common, and they're even more common when you get older. We've already talked about in women, there's already an anatomical disadvantage that we have because we only have this little short urethra. But men can also get them, and men as they get older, if they are wearing a Depends and they're sitting in urine, or if they have a Foley catheter, a catheter that's staying in there, they're at much higher risk of getting a UTI. So I'm thinking of one of my clients, Lena. She was repeatedly hospitalized after a UTI, and her daughter was frustrated and hired me to help. So I noticed that Lena had been given some overactive bladder medications because she had been having some symptoms of urgency. Well, guess what happens if you give a medicine for an overactive bladder? It relaxes the bladder, and now she turned into a urinary retainer, but nobody had checked. So I asked for them to check some post-void residuals if they would mind doing that, and they did, and guess what? She was indeed retaining urine. So then that led them to say, oh, we need to stop this medicine. They stopped the medicine, and while she still does get a few UTIs, they're not nearly as frequent or as bad as they used to be because she's no longer retaining urine. When people keep going on repeated bouts of antibiotics, they can select out for the bad bugs. And what I mean by the bad bugs are the drug-resistant bacteria. You know, if you always have a mix of bacteria in you, and if you give an antibiotic that kills off 99 but leaves one, and that one is resistant to the bacteria, to the antibiotic, and that one then grows, now the normal antibiotics aren't working, and now you've got to go hit with bigger and bigger antibiotics. And those bigger gun antibiotics have more side effects. They kill off more of your gut flora. You want to try to avoid multiple bouts of antibiotics if you don't need to. How do you know if somebody has a UTI? Well, the classic symptoms are change in frequency, urgency, or burning. It's the change. Frequency, urgency, burning. Sometimes fever, sometimes not. Good caretakers will tell me her urine doesn't smell the same. There is a change in smell that often happens. And another common thing that hopefully you're aware of, but if you're not, be aware. Often before a person even voices that they're having urinary symptoms, they have a change in mental status, meaning they suddenly become confused, or they're suddenly just agitated and just they're not themselves. When that happens, think UTI and help that person or get a urine test. Urine tests. I've also seen a lot of confusion around the two basic urine tests. There's two tests that the doctor should send. One is called a UA, and I'll tell you what it is, and the other is a urine C&S. The UA is the urinalysis. A urinalysis is literally what it sounds like. It's the analysis of what's in the urine. Should be back within a few hours, maybe a day of it going out. A urinalysis will tell you if there's bacteria, if there's white cells, you know, protein, all the stuff we want to know. It's really just looking at it under a microscope. So the urinalysis comes back quickly. The urine C&S, do you know what the C is? Culture. They take the urine and they put it on those nice little auger plates that we all played with back in science class, and they look to see what grows in the culture. And the S from urine C&S is sensitivity. That's which antibiotics are those particular little bacteria that are growing on the auger plate sensitive to. So a doctor should look at the results of the urine C&S and say, oh, this bacteria, I can't use Bactrim, but I can use Keflex or whatever, because it'll come back to them what these particular bacteria in this particular person is sensitive to, so that they can select the best antibiotic that's going to work out of the gate. So that culture and sensitivity, though, takes 3 days to come back. And that's where I see a lot of confusion. I've even had nurses say, oh, no, we won't get any urine results for 3 days. No. You get the urine results. The urinalysis is back within hours or a day. And a doctor can see on that, based on the number of white cells and patterns of some of the chemicals, whether there's an infection. And they often will start an antibiotic early at that point, and then change it when the culture and sensitivity comes back. I think, Yeah, oh yeah, sorry, no, I got myself slightly confused there. Only other thing to mention to you is if you have a urinary infection, you're at risk of the bacteria going into your bloodstream. That becomes sepsis. So the reason that people are frequently hospitalized with their urinary tract infections is either they are uroseptic or they're at risk for being uroseptic. Early sepsis is a person just doesn't feel well. They're really they're tired, they're feeling sick, they're sweaty, they're not right. If there's any doubt, get the medical care. The other thing that can happen is people can also develop back pain. And if they have back pain, that means there's a chance the kidneys have gotten involved. And if the kidneys are involved, you need stronger antibiotics. Okay. So most urinary tract infections are manageable, but if someone is having multiple UTIs in a year, it's worth trying to figure out why. So today we discussed arthritis, spinal pain in the urinary tract. I'm hoping that now, next time you see the doctor for these issues, you're going to feel like you've got more vocabulary. So before I take questions, I just want to tell you one thing. I write a monthly essay. It's a short essay, about 1,000 words, and it's on Substack. It's called The Fog Light. If anybody would like to read it, my email's up there. You can email me or you can go on to Substack if you go to Substack, and you can sign up. And when I'm not giving talks or writing, I'm a private patient advocate. And so I've used my clinical and my business skills to help people get the best care possible. Happy to take questions, and if I can help you, please let me know. You're gonna take that one.
When you go for a second opinion, do you tell the doctor up front that's why you're there, or do you just let them diagnose you and see what they come up with?
So the question was, do you tell them or do you not tell them? Depends on what you want out of it. So you use your judgment. There's no rule. So in the case, so for example, in the case what I told you of the guy who went to New York for the 2 opinions, he told each of the New York surgeons that he was what the doctor in Poughkeepsie said, but didn't tell them about the other because he didn't want to influence or bring up the competition. And the woman who went to see the urogynecologist, she did not say anything. She wanted to see separately what would happen. So there's no right or wrong. Sorry, the only other thought on that, if you are doing a second opinion around, say, like a cancer surgery, and you're going at a distance for that, then they often want to know, do you have a local physician to manage your cancer? And so sometimes you want to say, yeah, I'm here for a second opinion to see, do I need to have surgery? So it's a judgment call. Sure.
Could you go back to the knee implant you had?
Sure.
All those parts there that are showing white, I assume are metal.
Yes.
So why does it hurt after 20 years?
Oh, why does the joint replacement?
Yes. What fails?
It fails. It wears out over time.
But there's no nerves in the metal.
Oh, it's not. What happens is where it is put into the bone,
Yes,
loosens up, and then it starts rattling around in there, or you can get little fractures, or even the replacement itself can sometimes develop a problem. But if there's a crack and now it's moving in your bone,
sure.
That's going to stretch the periosteum that lines your bone, and that hurts.
Oh, so it's not the joint itself. It's the fact that it loosens up. So
Yes.
you get a new one, they put a larger one in there, right?
Yep.
A larger post.
Yep, that's exactly right. And the technology around how they secure them, the cement, all of that stuff keeps evolving and getting better and better and better.
Oh, thank you very much.
Sure.
So number one is I'm on year 7 of my knee replacement. I haven't had a problem yet. But
Good.
my other question is going to the back. You mentioned a procedure that I didn't catch the name of and I've never heard of.
Epidural?
No. It was the man.
Oh,
Actually, it was a man that went for.
microdiscectomy. The
Right.
microdiscectomy?
Yes, I don't know what that is.
So in a,
No, she got it.
yeah, he had a microdiscectomy.
Right,
Let's see. Oh, wrong way.
right.
So in a microdiscectomy, this disc has bulged out and is now plopping on and sitting on the nerve root. So they don't take out the whole disc, they take out just a piece of the disc that's sitting on the nerve root, hence microdiscectomy. They're just taking out a little piece of the disc and sort of aligning things so that there's now plenty of space.
So they just.
And these things change with time. I mean, one of the things we didn't get into is that back surgeries for years, and I'm talking a couple decades ago, were very, very, very well reimbursed. And so we had many people being offered surgery over and over and over again. And we ended up developing an entire generation of what we called failed back syndrome, where people just had, 3, 4, 5 surgeries, and then they have scar tissue. And now if you've got scar tissue sitting on your nerves, you can't clean out the scar tissue because you're going to get more scar tissue. So now they used to, like in his case, they might have wanted to do a big fat fusion and take out the whole disc. Now they've learned that less is more at times when it comes to spinal surgeries.
If you have osteoarthritis in your ankle, is there any replacements for that?
That's a good question. I haven't seen ankle replacements, but that doesn't mean they don't exist. If you want to know, go to the Hospital for Special Surgery in New York, because they're terrific there. And I rarely say that about hospitals, but everybody I know, and I have no relationship with them, has had a good. That's interesting. I didn't know that. Thanks.
Gerda, someone once told me years ago that if you're going in for surgery, and that could be back or knee or hip or whatever, you should ask your surgeon how many of those operations do they do in a year. And you want to get someone who's done, a good number. What should one say when one asks a surgeon, well, how many knee surgeries do you do? Or how many, disc, whatever, and they don't want to answer you, or they answer in a different way. Well, I know what I'm doing, or how do you deal with that?
So that's a great question. And we could do an entire talk on how do you select the right doctors, because I have a lot to say on that topic. But for your specific question, I call it you never want to be that really interesting patient. Meaning if you're going for surgery, man, you want to be as routine as humanly possible for that doctor, because you want that doctor to have seen 100, I'm making up a number, but a lot of people like you, because maybe you have that one little anatomic variation that somebody who only does 2 of these a year has never seen, but the guy that's done 100 a year has seen a bunch of times. So you always want the guy within reason who's done volume. The reason I say within reason is that you don't want to go to a mill either. And so you have to be careful. Cataracts, and I'm going to go off on a little tangent, but cataracts is a prime example of, there are a lot of cataract mills out there. And you want to go to someone that you're comfortable with and that you can have confidence in. When a surgeon won't answer your questions, get another opinion. I found you can go, especially if you have Medicare, to as many people as you want, as you can tolerate. And each time you go to someone who's in that same specialty, you know just a little bit more because you're learning along with this and you're asking better and better questions. So just keep going. Maybe that's a good doc for you, maybe not. But you might as well compare. If you're going to buy a sweater, right? You're going to spend time looking at a couple different sweaters. If you're going to buy a surgery, you want to look at a couple different surgeons.
Any dietary recommendations if someone is dealing with arthritis, example, in the joints of the hand?
So for arthritis in general, the dietary recommendations are anti-inflammatory diets. So an anti-inflammatory diet is limited to no processed foods, meaning if it comes in a bag, be careful. Because there's so many additives in processed foods these days. And again, that's another talk for another day that I have a lot of opinions on. And then whether it's a Mediterranean diet, for different people, different foods cause inflammation. For some people, it's dairy. For some people, it's gluten. Look up anti-inflammatory diet and see what fits within your world of what you eat and what you might want to change. And if you're going to try to make a change to see if, let's say, okay, your hands are inflamed and you want to know, give it 2 weeks without that food. If after 2 weeks you don't feel any different, it wasn't that food. And if you like it, eat it again.
Just a comment about what you're referring to about number of operations a person has done. I was reading that the worst guy you can get is the head of the department. Believe it or not, you may think he's the best, but he does the least number of operations in a year. Where the guys that are really on the firing line are the surgeons themselves, but not the head of the department.
So yes, and it may well not be that head of the department who's actually operating on you. So remember I mentioned the fog light? One of the things I wrote about was who is the lack of transparency in operating rooms. And what I'm talking about is in an academic hospital, and many hospitals now, even if they're not like giant, Mass General types, will have residents and fellows. In a teaching hospital, the resident or fellow may be the one who's actually doing the operation. And I had that happen to a client of mine who specifically said, I don't want a resident or fellow operating on me. And she was told, well, okay, and I'll be there no matter what. And she was so worried about this, I pulled the operative note for her, because after every surgery, they have to write up an operative note. And her doctor was not even listed as the operating doctor. It was a different name. She's like, who the heck is this? I looked him up and it was a fellow who had done her surgery. And, she was appalled and I was appalled, which is part of why I wrote about it. So yes, it may be in part because they haven't done volume, but it may also be because they're not doing your surgery. So, but they might be terrific and they might have great techniques and I wouldn't rule them out, but know what I'm all about. One of the things that I just believe in so strongly is informed decision-making. Get the information and then decide what you want to do with it. Maybe the fellow operating on you and the big cheese standing over his or her shoulder is okay with you. Then great, but you should be informed and your wishes should be respected. Okay.
Oh, does someone else want to? If one is going in for whatever kind of surgery and it's offered outpatient or it's offered one night in the hospital, do you have any suggestions of what we should ask the doctor, why there's two kinds of surgeries for one to decide which one to pick?
So the same day versus overnight is almost always about medical condition. So if you have medical conditions that put you at risk, heart failure, history of pneumonia, delirium or dementia history, things that would put you at risk from having a good recovery at home. You want to make, sure that you're going to be kept overnight to be watched to make sure that none of these bad things happen. Congestive heart failure is one of the most common reasons because in surgery, you're given a lot of fluids. And if your body decides, too much, I'm just going to drown her lungs, you want to be there so they can give you diuretics and just immediately take care of it. Usually it's very temporary, but it's a medical discussion more than anything else.
Well, thank you.
My pleasure.
And you only covered 3 of the 10 possible topics. Well, it's very,
I'll be happy to do it for you.
thank you.